Joining me now are some of the leading lights and luminaries in type 1 diabetes research. On my right, Dr. David Pearce, President of Sanford Research and Health, as well as Senior Scientist and Professor, will tell us about Sanford's unique three-legged stool approach to tackling this devastating disease. We'll learn about ways to rebalance the immune system from Dr. Jeff Bluestone, who's sitting to his left, Executive Vice Chancellor and Provost at the University of California in San Francisco, who has served as Director of the UCSF Diabetes Center and the Immune Tolerance Network. Doug Losordo, immediately to my right, Senior VP of Clinical Medical and Regulatory Affairs and Chief Medical Officer, will discuss a phase 2 study for type 1 diabetes that employs a patient's own Treg cells to prevent the destruction of islet cells in the pancreas. We're also joined to my immediate left, Dr. Doug Melton, co-director of the Harvard Stem Cell Institute, a pioneer in the field who began his work 23 years ago when his son was diagnosed with type 1 diabetes. And finally, Dr. Young Zhao, associate scientist at the Hackensack Medical Center, will describe groundbreaking research that was started in China and Spain using cord blood cells for patients with type 1 diabetes. The format will be that each scientist will present for just a couple of minutes on their particular area of expertise and research, and then it will be followed by a panel discussion. I'll turn it over to you, David.
Okay, thank you. So I'm absolutely thrilled to be talking about the Sanford project, which is Sanford Research and Sanford Health's drive to cure type 1 diabetes. So just to kick off, similar to with the rare diseases, just to remind you of the significance of this disease. I think it's always good not, to hear these numbers again. We're talking about 80 people get diagnosed with type 1 each day in the United States and 1.5 billion in healthcare costs. This is a significant problem. And while we know a little bit about predisposition, that if you're a diabetic, your child has a more likely chance to develop type 1 diabetes, we're still pretty much in the dark to the actual true basis of this disease, although we know a lot about the progression and pathogenicity of the disease. So we have this three-legged stool approach. The three-legged stool it's really like the compartmentalization that Henry really told us about, which is really you lose pancreatic beta cells, so well, let's regenerate them. But of course, the chicken and egg situation is if you don't really address what's destroying those pancreatic beta cells, then regenerating them may not necessarily be the way to go. The underlying autoimmune attack. And ultimately, as I alluded to, preventing the actual disease and truly understanding the basis. In some ways, I often think of type 1 diabetes as the pancreatic beta cell loss is a phenotype, and we truly haven't, established what all the routes to that pancreatic beta cell destruction could be, other than through the autoimmune response. But what precipitates that? And those are a number of factors that were discussed by Henry on that. So in summary, regeneration, what are we doing here is in Dr. Alt in the video sort of alluded to that a little bit. We have the pig models that Jill talked about for ataxia telangiectasia, and we're using those as well as additional pig models to really look at how we can deliver mesenchymatosized stem cells to the pancreas and for that ultimate cure in terms of regenerating pancreatic beta cells. Obviously, so many type 1 diabetics, we need to be able to regenerate those. Obviously, the other thing is in the autoimmune response is to modulate the immune system, and we'll be, I'll be turning that over to Jeff and Doug, who have a really tremendous, scientific discovery and clinical trial to talk about where they're really going to be restoring the balance of the immune system to stop that destruction. So if we can stop the destruction, then we can truly start looking to regenerate. And then prevention. We've learned from the clinical trials that we've done through the Sanford project that the mice tell us a lot of things. But that mouse, the nod mouse, is the model. It's been cured maybe 150, 200 times. I lose count. So we still really have to figure out the basis of what that disease is. And from our clinical trials, we learned that a few people do respond to the underlying biochemical findings or immunological findings from the mouse models. We need to understand that and find the true basis. If we could actually cure this disease in the subpopulation, that would phenotype them appropriately for us to identify the susceptibility and maybe the genetic factors that underlie this disease. And as I said, we're circling back and using those pig models to really help us understand how to deliver those therapies. So with that, I'm not going to talk about the Tregs study, the Sanford project study, and Jeff and Doug will be talking about that. Suffice it to say, if you just look at the little balance beam there, that's where we're rebalancing the immune system, and I'll let them describe that because we're very proud to be partnering with them for this clinical trial.
Jeff.
Great, and thank you all. I really appreciate an opportunity to talk to folks today. What I thought I'd start out by doing is to just drill down a little bit about what you've been hearing about this disease. I mean, type 1 diabetes really is a disease of the immune system. It's a disease where T cells, the sort of bluish cells that come out of the thymus, which is the organ that you generate your T cells, make mistakes and start attacking your own tissue. And it attacks it by recognizing insulin and other proteins in the beta cells that it shouldn't as foreign and starts destroying it. That leads to the turning into what we call effector T cells or killer T cells, the green cells here, which then go on and start destroying the beta cells, the islets that are making the insulin that are so important for your blood glucose control. So this is the problem. We've known this for a while since George Eisenbarth really first delineated this now some 30 years ago. So you ask, why haven't we been able to solve this problem? Well, we and many other groups have approached it initially by targeting the green cell and trying to see, could we eliminate the cells that are actually causing the damage? That would seem like a very obvious thing to do. Unfortunately, this population is very diverse. It's hard to identify which cells within the overall population in the human is responsible. And the drugs we use now to try to do it are drugs that are broadly reactive and unfortunately can have some side effects. So in turning back and asking, well, maybe it's more than just the green cells. Maybe it's more than just the effector cells that are a problem. And now it's some 15 years ago that we discovered that there was a very small population of cells that also came out of the thymus, so-called regulatory or Treg cells. And these cells turn out to be the policemen of the immune system. They make sure that any time an immune cell goes awry, starts attacking self-tissue when it shouldn't, that these cells come in and shut it back down. And it's a very powerful cell. It's operational in almost all diseases at some level. And in fact, patients who are missing this cell die within a year or two of age from just broad autoimmune disease throughout their whole body. So it was at this point in the early 2000s that we felt that rather than going after the green cells, the effector cells, maybe we could try to go after these regulatory cells. And if we could actually identify them and isolate them and use them, maybe that would be effective in this disease. And so what we've done first is to categorize and find out that these cells are not just important in a variety of autoimmune and immunological diseases, but are likely to be important in a whole series of other diseases as well. So anything we could do with this platform, if we could develop it, might have broad applicability, not just for type 1 diabetes, but beyond it for affecting immune balance. So how do we do it? Well, we actually do start out in the mouse in most cases because it's the best place to start. And the system we started was an islet transplant model where we were putting islets back into a mouse and looking at the immune system rejecting them. And what you see here is a picture of an islet that's being rejected. The green cells are these green effector T cells that are destroying the red cells, which are the insulin-producing beta cells. And what we found is if we put these regulatory cells in to these animals, we totally blocked the destruction of the beta cells. And now you see these beautiful red cells making insulin without any evidence of the green cells, the effector cells, coming in and killing it. And so that was the first demonstration for us that you could actually modify the immune response if you could effectively get this regulatory cell, which we now know is defective in patients with type 1 diabetes, back into the patients. And we could even show that after the mouse started becoming diabetic, this is right at the time the mouse started becoming diabetic, if we put these cells in, we could totally reverse the diabetes and get these animals back into a homeostatic state of insulin production so that they could maintain their blood sugar. So we immediately decided to try to do this in humans. We've spent the last 8 years doing that. And the first thing was, could we find the cells in humans? And we did, using a series of markers. And in the sort of trapezoid here, you'll see that we have the ability now to isolate these cells very effectively and take them out. In the second box, you can see that we can grow these cells outside the body, expanding them anywhere from 300 to 2,000 fold in a period of just 2 weeks. And at the end of that time, we can have billions of these cells in hand. They're not just more numbers, but they're also more effective than the cells that we took out in the first place. And we've corrected the defects that are present. And so we decided to test this in humans, and we created this phase 1 trial. It's a safety trial, and we learned a number of things in this trial. One is we could grow up and use a dose of 2.6 billion of these cells, which is quite a few of them. As I mentioned, they function even better than the cells that we took out. And we found that they stay around in the patients that we've treated for quite a long time, even seeing these cells a year after we transferred these cells back into the patients. And most importantly, it was a safe therapy. It's a therapy that, in fact, did not cause destruction of the beta cells, but looks like it may even protect the beta cells from destruction. This is just each patient and looking at their insulin production over time. And you can see several of the patients actually continue to make insulin even 2 years after the transfer of these cells. So where do we go from here? And you'll hear more from Doug, but I think the cure for this disease is going to take 3 things. First, I've already talked about being able to restore this immune balance by getting back the balance that was lost, and that's by identifying, expanding, and putting back in these regulatory T cells or drugs that might do that for you. You heard a discussion earlier on today about that. But I think we still have to worry about those green effector cells, and we need to combine our Tregs with drugs that eliminate those effector cells. We know drugs now like anti-CD3 and an LFA3 drugs that have been tested in a number of human and mouse settings, can in fact selectively eliminate some of the effector cells. And so we could restore, we repair this autoimmune response, and then finally, and Doug will tell you more about this, is we then have to replace. We have to put the beta cells back in that have been depleted through this massive immune response over time. And I think if we can do that, we'll end up with a stable islet population in an immune-tolerant individual, and hopefully we'll be able to treat and cure this disease.
Thank you, Jeff. Doug?
Great. Well, first of all, thanks to Robin and the organizers for putting together this spectacular meeting, and it's a delight to be here with you and this really terrific panel. So I want to talk a little bit broadly about how cell therapy will revolutionize medicine. I truly believe that 20 years from now or so, medical students will look back at the way that medicine was practiced now and in the past, and I think in some ways be astounded at how primitive medicine was and how chronic diseases were allowed to disable patients, and how we really just temporized with things like insulin rather than eradicating the diseases that are a result of the fact that we have left our normal, healthy state. So the vision of this conference, I would say, is that health is our natural state of being. Unless you have a genetic disease, you're born healthy, and most of us are lucky enough to live most of our lives being healthy. And you get sick with a chronic disease only when something breaks down, just like your brakes go out on your car. Well, in your body, as Jeff just very elegantly outlined, when your immune system breaks down, you end up with autoimmune diseases. And that's because your cells, the system of your immune system has failed. And great scientists like Jeff have begun to unravel the pieces of that system to allow us to repair it. So the idea is that we now have a mission to restore health, not to treat disease, but to restore health by leveraging the power of our bodies. I like to joke that, cell therapy is nothing more than 4 billion years of drug development, which is how long we've kind of been at this as human beings. Now, how do you get from treating disease to restoring health? You start with great science, but then you need bold investors and donors, to be honest. And David already mentioned that the name of this study is the Sanford Project. That's the result of the generosity of the Sanford Health System and Mr. Sanford that set that up to get this program going. And we need, of course, our investors who've invested in our company that are driving this study forward. And then most importantly, and this is increasingly in focus in the world of drug development, is the patient, and in the case of type 1 diabetes, patient and family-centric model of therapeutic development, really bringing the experience of the disease and the families into focus so that our therapies are specifically addressing that experience in a, we have to say, a holistic way, so that we're really bringing these patients and their families back to where they want to be. If you ask a patient with type 1 diabetes, what do you want? They don't say, I want a normal glucose. They don't say, I want to avoid the complications of diabetes. What they say is, I want to have not diabetes. I want to be a healthy person. And that's what cell therapy is really aiming to do. More specifically, and I think Henry and Jeff already alluded to this, here's how we start with a healthy, balanced immune system where effective function is appropriately balanced against regulatory function. In type 1 diabetes and other autoimmune conditions, the regulatory function is reduced. And what we're aiming to do, as Jeff suggested, is really giving people a booster dose of their own regulatory function by, and I'll outline the methodology for that in just a moment, with the goal of a rebalanced immune system where your body isn't attacking your pancreas anymore, your insulin-producing capability is at least protected, if not restored, and you go to being a not diabetic person. So here's the Sanford project, the Tregs study, as we call it. After folks undergo their screening procedures, they have blood collected and Treg cells are separated with the method that Jeff invented in his lab. So there's the blue Tregs that get separated out. We grow those cells now in our manufacturing facility after Jeff's group taught us that methodology. And now those cells, the patient's own cells, which are now expanded but also fixed. Part of what Jeff figured out was how to restore not only the numbers but the potency of the cells to do what they're supposed to do, to tamp down the autoimmune attack on the organ. So those new, improved, if you will, or I would say restored Tregs, brought back to their normal healthy function, are infused back into the patient. And then we start to follow the patients, and Jeff's already completed a 2-year follow-up in his pilot study. But really the goal here is to get rid of the insulin pen and rebalance the immune system. And so we're lucky enough to have started that study in partnership with the Sanford Health Group, and we're powering our way through the first cohort of patients to look at safety. 5 patients have been infused. We've got a bunch more in the queue, and we'll wrap up that first safety cohort, we think, by summer, and then hope to finish the enrollment of the entire phase 2 study by the end of next year.
Thanks, Doug. I'll turn it over to Doug Melton.
Yes, thanks for having me here today. It's a pleasure to be here. And I have good news since it's late in the day, and if you're suffering from jet lag like I am, I have a nice simple talk. Which one do I push? This one. So I'm going to talk to you about the other half of the problem. Jeff and Doug have described a nice attack on the immune system, which has to be solved. I'm going to talk about the fact that diabetics can't make their own insulin. So it's sort of obvious. A high school student would say, well, why don't you replace the cells that make insulin? Well, this is an obvious and simple idea. It's taken us more than a decade to achieve it. And if you just look at the top line here, you see a very simple diagram, beginning with a human stem cell, either an embryonic or an induced pluripotent stem cell. We have figured out how to educate it, that is, how to tell it what to do, by the right combination of 15 different factors in a 30-day protocol. And at the end, we get cells that do 2 important things. One is they can measure the amount of glucose, and secondly, they can secrete the right amount of insulin. Another way to think about that is that replaces the glucometer to measure the sugar in your blood, and the syringe or the pump that injects insulin. That's nature's solution to that problem. So what I'm going to show you in just a couple of slides is the status of this work, and then say a minute or 2 about the future. On the bottom left, you see that we set out to do this with 2 constraints. 1, that we would only study human cells, and 2, that we would do it at a scale that could treat human beings. So what you see on the left there is a spinner flask, which has a magnetic stir bar on the bottom. It's about the size of a coffee pot, and we can make in there enough cells to treat 1 patient. What do the cells look like? They form little spheres or clusters, as you see in the middle, where the colored cells are the insulin-producing cells. And on the right is something I'd like to emphasize, which is that these cells, for the first time, are human cells that respond correctly to to a glucose challenge. And you can see there, if you think of the 2 and 20, as 3 consecutive challenges, sort of like breakfast, lunch, and dinner, giving the cells glucose and asking, do you secrete the right amount of insulin? And the answer is yes. They each time read the glucose and secrete an amount of insulin which is indistinguishable from that when we test human cadaveric islets. So that's what the cells look like. I might just mention, some of you might wonder why, if that's so simple, why did it take so long? I'm not really sure I have a good answer to that. My children ask me all the time, they're sick of seeing this diagram. They want to know, why did it take more than a decade? I guess part of the answer is we made a lot of stupid mistakes along the way in trial and error. But at least we're to the point now where we can make large numbers, literally billions of human pancreatic beta cells from any person in this room. The next slide shows then what we've done with those. I'm not going to spend much time on all of the different mice that we can cure. So immunocompromised mice can all be cured of their diabetes. In the top left, you see the islet-like structures that we transplant. But as other presenters have said, there are many ways to cure a mouse. What I wanted to show here instead is on the bottom left, a physical protection, a chemically modified alginate, which when transplanted with our human stem cell-derived beta cells into mice in this case, which have a fully competent immune system, an active immune system. You can read the graph and see that on the bottom, the blue and the green are indistinguishable. There's a healthy mouse versus one, or compared to one that has been transplanted with our human-derived stem cells. And so now we're some 6 months out where we can keep a mouse with normal blood sugars, that is using human insulin. The challenge, nevertheless, to go back to what Jeff and Doug said, is that there still has to be some kind of protection for the immune system. So to be clear, even if we made an induced pluripotent stem cell from a type 1 diabetic, turned it into a beta cell, and transplanted it into a patient, without protection, those cells would be killed. So my last slide here is to just say a bit about my view of what are the next steps in the next couple of years, I hope. The first thing is, now that we've shown we can make the beta cell, or the insulin-producing cell, we've moved on to make the other cell types. We can make alpha or glucagon-producing cells, which, as many will know, could be relevant to treating low blood sugars. In addition, we've just recently accomplished the synthesis or the production of a third type of cell in the islet, the delta cell that makes somatostatin. That's relevant in my view because, at least in mice, that cell is very important for controlling the proper regulation of insulin secretion by the beta cell. I don't think anyone really knows what the yellow pancreatic polypeptide producing cell does, so we haven't really given it much attention. And unless someone can convince us otherwise, we're going to ignore the green cell, the ghrelin producing cell, because that affects appetite. And as far as I know, at least from my own children, the diabetes does not have any effect on appetite. So if we move to the right, I'll finish by just saying where I see we need to focus now. We need to perfect the function of the cells that we're making. They work very well, but they're not perfect. They're a little bit off in their regulation at low glucose concentrations, and so we have to work to perfect their physiological response. And in terms of function, as I've indicated, we'd like to set the challenge for ourselves of making a human islet, making the alpha and delta cells as well. The real challenge, which is what our other speakers have described, is how are we going to get these cells to survive post-transplantation? Encapsulation is an exciting and viable option to create some sort of device, a tea bag, if you will, that will allow us to put these cells in and have them survive. But I think most of us here believe that in the long term we need biological protection. We are now moving to GMP production of these cells to plan for getting them into transplants. That won't happen in the next year, but I'm very hopeful that will happen in the next few years. Thank you.
Thanks, Doug. Young?
Good afternoon. First, I appreciate the organizer giving me this opportunity to introduce our works. In last over 10 years, we developed a stem cell educator therapy from identification this new type stem cells in cord blood and to its clinical applications. Today, I'm going to focus on the phase 2 clinical data, show how stem cell educator therapy can correct the autoimmunity and improve the metabolic control. These two key issues for the treatment of type 1 diabetes. On the left panel, you can see the procedure. The stem cell educators, like a medical device, already got FDA registration. It's a stem cell attached on the bottom of each layers. We use a apheresis machine, draw the blood from per patient, can isolate the immune cells, then transfer into the device. The stem cell can directly modulate and correct the immune dysfunctions. After the treatment, the stem cell treated the patient's own cells return to the patient's blood. Stem cells stay outside in the device. This is a closed system and continue process. Usually take about 8 to 9 hours. On the right slides, you can see that's the signaling mechanism inside the educator, how stem cell modulate the patient cells through the surface molecule and the soluble molecule can modulate the T cells and monocyte macrophage. This is the key player for the autoimmunity. Stem cell educator therapy can restore the immune balance. Here, this is clinical data from Chinese trial and Spanish trial. After treatment, the patient, the naive cells, the percentage can dramatically increase. Most importantly, the autoimmune memory T cells, both CD4 and CD8 effector T cells, that's the key player to kill the islet beta cells. After treatment, you see their percentage dramatically declined after 18 weeks. Interestingly, the central memory T cells increased. So on the right panel, you can see the regular T cell percentage in the treated group increased. For the control group, no difference. Stem cell educator therapy can restore the islet beta cell functions. We use the C-peptide as the indicator for beta cell function. From the top right panel, you can see we have 3 groups, Group A, Group B, and Group C. Group C is control group. Group A has some residual beta cell function left. Group C is a long-standing severe type 1 diabetes. No C-peptide begin the treatment. You can see after treatment, just one treatment, we follow up 6 months, their C-peptide dramatically increased, even in the severe Group B patient. We use the OGDT test. The patient drink 75 grams sugar water. We confirm the beta cell regeneration. You can see before the treatment, no response. After treatment, 4 weeks, 12 weeks, and 40 weeks, you can see the C-peptide increased. For sure, there are beta cell replication. So we got a similar result in Caucasian population from Spanish trial. It's differently for the severe type 1 diabetic patient. If no C-peptide, they did not show the beta cell regeneration. What's the reason? We performed the mechanism studies. We find the Chinese pancreatic islet beta cells strongly expressed M2 receptor. You can see the right panel, top right. For the Caucasian population, the pancreatic alpha cells expressed M2, not on the beta cells. This molecule disparity causes the difference. The bottom right panel, you can see the triple staining, which showed M2 involved the beta cell replication. After over 20 years, the basic research and the clinical research, I'm glad we find the safe technology. They can correct the multiple autoimmune disease. So here, they show you examples. The alopecia areata, same like type 1 diabetes, is T cell mediated. This just the T cell kill the hair follicles. The patient lost the hair. You can see same approach, same technology, treat this patient. After 4 weeks, the small hairs grow up. After 12 weeks, almost grow up. We follow up 2 years, no relapse. Find a cure for this patient. This data provide visible evidence to demonstrate the immune modulation of stem cell educator therapy leading to the tissue regeneration. And on the right panel, we have another clinical trial. So we demonstrate stem cell educator therapy can correct insulin resistance and improve the beta cell functions in type 2 diabetic patient because the end stage of the type 2 diabetes is similar like type 1 diabetes. Okay, thank you so much.
Thank you so much, Young. So the first question that I had was, and Doug, I think, Doug Losordo, you had mentioned that the Tregs are more effective in functioning. What do you think is the mechanism behind their improved function in addition to have greater number?
You know, here's what I would say. I would say that the Sanford project, the Treg study, will provide data that has never been provided before. So, you know, Jeff, I would say, you know, has been a pioneer in the field of, has led to a great deal of understanding of how Tregs work. But really the ultimate experiment to determine how they work is the experiment that we're doing to see if we can dial back the autoimmunity and diabetes. So that's the clinically desirable outcome. But this is actually you know, Jeff did the first study, phase 1 study, and now we've got this phase 2 study that's a controlled study where we're putting in these cells that have what we think is enhanced function, FOXP3 levels, STAT5 phosphorylation, you know, so all the things that we think go along with a functioning Treg. But by putting those cells back into these kids with type 1 diabetes, we're then going to be able to monitor their immune systems, look at the cells, really fully phenotype the cells, and, if you will, phenotype the immune environment before and after the cells are deployed. And so really, this is the first chance we're having to determine what the mechanisms are by, I would say, looking at the subjects who have a clinical response, look what happens to their immune system, and as I say, the first time that we're ever really be able to make those sorts of observations. So, you know, the answer to your question, I think, will start to be unraveled when we start to look at this data. Jeff, do you want to add something to that?
I think I'd like to just sort of intersect, you know, what I said this morning about rare diseases and the personalized approach that we're taking, and the presentations on cancer this morning. Again, it's all about that personalized approach, and I think Doug, you know, articulated it very well. This is the first time we'll actually be really able to dissect out the immune system and how these cells, which are clearly very important to understanding not just the basis as well as the treatment of the disease, and gathering that data. So I think, you know, that's really the way we need to look at this. You know, maybe I may be going a little bit too far in saying this, but I think ultimately type 1 diabetes will be divided into subtypes of diseases, just like we're doing with cancers now, based on those drivers of what's causing the problem with the immune system.
Maybe I'll say a little bit about the science. And the science is actually pretty interesting here. It turns out remember, we're talking about this fine balance, right, between homeostasis and response to a tissue, in this case, the pancreas. Inflammation, the actual act of inflammation, is really bad for regulation. Whenever we're in an inflammatory setting, which is common, unfortunately, we're finding out it's true in Alzheimer's, it's true in type 2 diabetes, it's true in a lot of things. Inflammation compromises the regulation of the immune system. When we take the cells out and take them away from the inflammatory environment and expand them for 2 weeks, we see the recovery of a lot of the inherent functional activities of the cells that were lost during inflammation. So that's actually what happens. Now, maintaining that back in the patient again is what Doug's talking about. How do we ensure that we maintain it back in the patient again? But this is all about trying to repair a cell that's been broken due to an inflammatory response.
So that's a great segue to the next question. I'll turn to the scientists and colleagues on the left. So David mentioned precision medicine or developing specific approaches. Patients and scientists are looking at the burgeoning field of science that's being developed around type 1 diabetes. How do we know who's going to be the most appropriate patient for the right intervention? How do we personalize this in a world of big data and genomic medicine? Doug, I don't know if you want to address that.
I don't have any interesting thoughts about that. I tend to think instead that we should aim for a generic solution. So I like the idea of making beta cells that are essentially universal. They could go into any patient, largely because I think the cost of personalized medicine, where you begin with an iPS cell for each patient, will be so high as to be prohibitive. But I hope someone will prove me wrong.
Comments from other members of the panel?
Well, I think if you truly want to treat the disease, the ultimate goal is to prevent the disease. And so, Doug, completely agree in terms of, when it comes to replacing the cells, you're going to be treating the underlying disease that's there. But I think we have that unique opportunity now with genomics and all of the other epidemiological environmental information to dissect out why these individuals are actually losing their pancreatic beta cells. And then once we've cracked that nut, then actually we can actually be prophylactic in identifying the individuals that are going to have the disease. And I think that's where precision medicine will have a huge impact on diabetes.
So, David, how would you suggest we go about identifying individuals at risk, aside from first-degree relatives, for example? Obviously, we're living in a time now where the expectation is we will identify those individuals, and broad-based population screening is now being done in countries outside of the U.S. What do you see as the path forward there?
Yeah, so my personal bias, and having spoken to a number of people in the field, is that with each clinical trial that we have, there will be some type of response in a subset of those patients. So we really need to identify why certain patients are responding to a particular intervention. So we can say 5%, there's a 5% chance if you have a parent that you're going to develop type 1 diabetes, and we know the genetic association studies have not revealed the basis there. However, if 5% of the patients actually have a complete recovery of beta cell function from one particular approach, then it gives us a subpopulation to really identify the basis of why they develop the disease. And we know, am I talking about what's going to happen in the future? Absolutely, because of some of the trending that we're seeing with some of the other immune approaches that have been in this disease. So my point there is when I said that type 1 diabetes, pancreatic beta cell loss is a phenotype, there will be a phenotype that comes from a clinical trial. That phenotype will be restoration of insulin secretion, and if we can pull those individuals out, then do the genomic association studies, then we'll be able to subtype those individuals and come up with very unique cures.
Fair enough. We heard the concept of combination therapies and sort of attacking the, if you will, the autoimmune piece of this, and perhaps at the same time looking at restoring beta cell mass or beta cell numbers. So I'd like to get the panelists' thoughts about combination therapy as a therapeutic way, both, if you will, on the prevention side as well as on the treatment side.
I want to add some comments. For type 1 diabetes, it's really complicated. It's not only target islet beta cells. The autoimmune T cells, they also can kill some other tissues. Like some type 1 diabetic patient, they have Hashimoto, also has some alopecia areata, also have colitis, okay? So that means the autoimmunity not only inside the pancreas, they're also outside the pancreas, okay? So that's, if you only a single clone, single therapy is not works. So I think, in the last 30 years, in this field, it's just the targeted T cells or B cells or other regulatory, like a CTLA-4, some surface co-stimulating molecules, does not work. You need to combine them together. The reason for stem cell educator therapy, you saw the data show the miracle. I think the key point, these stem cells expressed the autoimmune regulator, the AR protein. Usually is Alzheimer's expressed, but after become adult, Alzheimer's lost the function, but a lot of autoimmune disease developed. So we find these stem cells, strongly expressed AR proteins, they can restore the immune balance, just like the artificial Alzheimer's, we treated the patient. Hopefully, this can lead into beta cell regeneration if we treat it at the early stage.
Okay. Can I make a comment about this?
Sure.
Combination therapy. So it's really interesting. I now live kind of in two worlds. I live in the autoimmune world, which I've been for a long time, and I'm starting to live in the cancer immunotherapy world, which we're going to hear a lot about tomorrow. And what you're going to hear tomorrow is how explosive the progress has been in combination therapies in that field as a consequence of a single dramatic success that happened. Frankly, you had to start your talk earlier today about the fact that our only approved drug for diabetes, type 1 diabetes, is insulin. I mean, that was discovered 180 years ago. If we can get an immunotherapy approved in diabetes that would find a baseline for now adding other things and attacking things, I think the field will dramatically accelerate. And I do believe that fundamentally, like in every other disease, from organ transplantation to cancer to other autoimmune diseases, combination therapies are going to be necessary here because we're going to have to get the immune system back into homeostatic balance. And if we can't get in there early enough, we've got to somehow get the beta cell function back going. So it's really about how we get this started. And a disease, which is not like cancer where you don't die in 6 months, so it's a harder disease to do with it. But I'm absolutely convinced that we have to be focused on combinations.
So we heard some unfortunate news recently about drugs not being approved for rare diseases. And I think it was in Duchenne's that the FDA, the AdCom, actually did not recommend approval. How do you think, and perhaps in a larger way, how do you think we're going to pay in some respects for the therapies that we continue to develop, facing regulatory uncertainties around potential therapies? How is this going to be paid for? Who's going to pay for it? And if in fact we're dealing with diseases like that that are not currently, when there is no treatment and drugs don't get approved, how do you see a business case if you can comment on such therapies being paid for?
Well, I'll take a stab at that. You know, I think that, you know, if the premise of my first slide is correct and the goal can be achieved, that is, if the goal of restoring health to some degree can be achieved with the attendant beneficial effects to the patient, that is, avoiding the complications of diabetes by, in fact, having an immune system, and I agree with Jeff, it's not going to be a single agent, but it'll be multiple agents that ultimately get the immune system back in balance, and then maybe some of Doug Melton's work to restore the lost beta cell function. I think those, the economics of it actually end up working out. You know, if you can make a diabetic not a diabetic for the next 30, 40, 50, 70 years of their life, that has obviously tremendous not only health economic impact, but of course societal impact. They're living a normal life. They're contributing to society more normally. And so I think the economics of that do ultimately make sense. It's incumbent on us to understand the economics and make sure that they make sense, but I think they do.
The other thing is we're seeing more and more collaborative science now. I mean, individuals working together on interdisciplinary approaches. So science and research is a team sport, but so is healthcare. So, you know, you need to have an integrated system where, you know, where you work your clinical trials into, you know, clinical practice and working with the payers and the providers all together in terms of, you know, optimizing the process. Just that alone will reduce the cost of development.
We have 45 seconds left. What am I going to tell my patients on Monday about what to expect in the next 5 years?
Data.
Data, okay. Well, thank you all very, very much.
Yeah.